Dear Graziella, dear Tom, ladies and gentlemen, first of all, I want to thank again Fernando and all the other members of the organizing committee. It is really a big pleasure to be here. And I want to apologize for my absence during the postgraduate course. The organizer asked me to give the same talk today, so I will do my best to recover. And speaking about acute kidney injury in patients with cirrhosis, I should remind you that almost 6 years ago, we moved from our old definition of acute renal failure in cirrhosis, that was an increase in serum creatinine equal or higher than 50%, to a final value of serum creatinine equal or higher than 1.5 milligram DL, to the KDIGO criteria, that are based on two parameters: the increase in serum creatinine and the reduction of urinary output. Why we did this change? Because first, we want to share the philosophy of the KDIGO criteria, that is to take care even of small increase in serum creatinine in our patient, because small change in renal function have a deep impact on survival in our patient. And the second reason is that in several perspective studies, we proved that from a statistical point of view, the KDIGO criteria based on the increase in serum creatinine were much more accurate in the prediction of in-hospital mortality than our old conventional parameters. But let me go back, because if we focus on the increase in serum creatinine, nowadays the diagnosis of AKI can be done either in presence of an absolute increase in serum creatinine equal or higher than 0.3 milligram DL in 48 hours, or a percent increase in serum creatinine equal or higher than 50% in 7 days. You can see that there is a staging system that is based on the amount of the increase in serum creatinine from baseline, so less than twofold grade 1, less than in between 2 and 3-fold grade 2, and higher than 3-fold grade 3. Now, for the prognostic accuracy of the KDIGO criteria, the stage of AKI is crucial. This is just the state of AKI at the first fulfillment of the KDIGO criteria. You can see that patients with AKI stage 3 and 2 have the same in-hospital mortality, much higher than in patients without AKI, much higher than in patients with AKI grade 1, and finally, patients with AKI stage 1 have a higher in-hospital mortality than patients without AKI. So when we accepted the KDIGO criteria, we proposed a new algorithm for the management of AKI in patients with cirrhosis. So you will have the initial AKI stage 1 on your left and all the other stage on your right. The first group of patients should be treated as soon as possible with very simple measure that you all know. In case of response, everything is fine. In case of no response without progression of the AKI stage, any further decision should be taken case by case. In case of no response with progression of the AKI stage, the patient moves to the right side of the algorithm and should receive the plasma expansion with high doses of albumin. That was the treatment that patients who were already on the right side of the algorithm received from the early beginning. In case of response, everything is fine. In case of no response, the patient should be checked for all the other diagnostic criteria of hepatorenal syndrome. If the patient does not fulfill the criteria, it will be treated when needed in some way. If the patient fulfills the criteria, it should be treated immediately with vasoconstrictor plus albumin. We also suggested that for the diagnosis of AKI based on the increase in serum creatinine, we can use as baseline a value serum creatinine not only during the last week, but also during the last 3 months. At that time, we do not consider the second parameter, that is the reduction in urinary output. But if you have a patient with a bladder catheter, with a urine flow meter, you should use it. And you can see that the criteria is a reduction of urinary output below 0.5 milliliter per kilo of body weight per hour. There is also, in this case, a staging system based on the length of oliguria or of anuria. If you can do, please use both the criteria, because this will increase the sensitivity of the tool you are using to make the diagnosis, and also the accuracy of the evaluation of prognosis, because you can see that the survival at 1 year is lower in cirrhotic patients with AKI diagnosis with both the criteria than when AKI is diagnosed only on one of the two criteria. But let me go on. The second step after the diagnosis of AKI is to differentiate among the different types of AKI, so acute tubular necrosis or ATN AKI, pre-renal AKI, hepatorenal syndrome, HRS AKI, and post-renal AKI. Let me say that in most cases, pre-renal AKI is resolved by plasma volume expansion. Let me say that post-renal AKI is rare, so the real problem is to differentiate in between ATN AKI and HRS AKI. And what we have our old definition of hepatorenal syndrome, that is a functional renal failure, so without parenchymal damage. So in clinical practice, what we do is to apply the criteria for the diagnosis of HRS, from which we only remove the final value serum creatinine. So in clinical practice, we rule out the presence of a significant parenchymal and in particular tubular damage on the basis of absence of shock, no ongoing or recent treatment with nephrotoxic drug, absence of hematuria, no significant proteinuria, and normal renal ultrasonography. The question is, are these criteria adequate to rule out the significant tubular damage in our patient? And the answer nowadays is no, because if we apply a platform of new biomarker of tubular damage, you can see that abnormal values are present not only in patients with ATN AKI, but also in patients with HRS AKI. The higher number of biomarkers with abnormal values, the lower probability you have to confirm your initial diagnosis of HRS AKI based on the criteria that I stated before. Now, two questions. The first is, are some of these biomarkers useful in clinical practice? Probably yes. IL-18, urinary IL-18 and urinary NGAL may be useful to differentiate ATN AKI and HRS AKI in cirrhotic patients, particularly urinary NGAL, that seems to be more accurate to differentiate in between these two conditions. The second question is, which is the impact of the presence of a parenchymal damage on the efficacy of the treatment we have for hepatorenal syndrome? And the most common therapeutical option, as you know, is albumin plus terlipressin. Well, we should consider that in our hand, this treatment is effective in 60–70% of the cases. Nevertheless, this treatment was introduced when we thought that the relationship between portal pressure and the hemodynamic alteration was almost mechanist, in the sense that we only know at that time that there was an increase in the release of nitric oxide, of carbon monoxide, and so on. So at that time, we introduced terlipressin to counteract portal hypertension, to counteract splanchnic arterial vasodilation, and we introduced albumin to further improve the effective circulating volume. But nowadays, we know that the pathogenesis of decompensation in cirrhosis is quite more complex. And the main consequence of portal hypertension is probably bacteria translocation. And so bacteria translocation will induce a state of inflammation and oxidative stress that is responsible for the macrocirculatory dysfunction and for the reduction of the effective circulating volume. There is no other mechanism by which portal hypertension is capable to induce the macrovascular dysfunction. Then, the reduction of the effective circulating volume together with inflammation and oxidative stress may cause ascites on one side, and then may also cause, through a vicious circle, the appearance of organ failure with or without the intervention of precipitating factors. If this is the new pathogenesis of decompensation in cirrhosis, we cannot think anymore that the hepatorenal syndrome is only related to renal hypoperfusion. This is not more true. There are several other factors, such as, for example, microvascular dysfunction. What is it? It is, for example, a lower rate of peritubular vessel with normal flow and higher rate of peritubular vessel without flow. Then, in presence of jaundice, there is also a direct tubular damage. In patients with hepatorenal syndrome and jaundice, bile casts were found in 100% of patients with hepatorenal syndrome. And finally, more important, there is inflammation. What does it mean? It means that at the glomerular level, dams and pumps filter and are binded by specific receptors that are present in some epithelial cell of the proximal tubule, who will produce a second signaling, TNF-alpha, and the final result will be the functional block of all the proximal tubule. This means an increase in the delivery of sodium to the macula densa, and the consequence will be the fall in GFR, that is the final cause of AKI. So if this is now the pathophysiology of hepatorenal syndrome, which is the consequence of this new concept of the efficacy of the treatment, well, you know that in patients with acute on chronic liver failure, the intensity of inflammation is increasing progressively, move from the grade 1 and the grade 3. Well, you can look here that the efficacy of the treatment with terlipressin plus albumin for the same value of the baseline serum creatinine is going down, moving from ACLF grade 1 to ACLF grade 3. But in this slide, there is another important message for clinical practice. You should start the treatment as soon as possible, because if you wait that serum creatinine go beyond 3 milligram DL, the rate of efficacy of the treatment is going down. And this is why we removed from the old classification of hepatorenal syndrome type 1 HRS. Now we speak about HRS-AKI, so that there is no more cutoff limit of serum creatinine at which we can do the diagnosis of HRS-AKI and start the treatment. Well, just another concept about the treatment, because from the beginning terlipressin was proposed as intravenous boluses. This is not the best way to use the drug, because as you can see, after one bolus of terlipressin, you can get a reduction of portal pressure in about half an hour, but the effect doesn't last more than 3 hours. And the time between one bolus and the next one ranges in between 4 and 6 hours. So the best way to use the drug is to give it by continuous intravenous infusion. We proved that Terlipressin by continuous intravenous infusion has the same efficacy than terlipressin given by intravenous boluses, but at much lower dose. And this means a better tolerability of the treatment, a higher number of patients who can tolerate the treatment. What about no responder? Of course, liver transplantation is the best solution for them and also for patients who responded to the treatment. And if the patient is not candidate to liver transplant, well, we can think to renal replace therapy with the same time that we use in the general population, with only one exception, that is refractory encephalopathy, because RRT is capable to reduce plasma ammonia. But the decision to start RRT in a patient with HRS-AKI should be well weighted, because the risk of mortality is quite high, particularly when the patient has more than 4 organ failures. So let me summarize what I said. AKI is frequent in patients with advanced liver disease. The KDIGO criteria should be used to make the diagnosis. A new algorithm should be used in order to manage HRS-AKI in cirrhotic patients. Nowadays, there is no more final cutoff of serum creatinine at which the diagnosis of HRS-AKI can be done and the treatment can be started. Finally, new biomarkers may be useful to differentiate in between HRS-AKI and ATN-AKI. Terlipressin plus albumin is the best we have to treat this complication. Thank you very much for your attention.